A very warm morning to all of you, and I'm very thankful for those kind words from my professor, Dr. Ratnakumari ma'am, who has really taught me the nitty-gritties of NICU, and completely a different topic from what was spoken. A very new topic on oils. I'm really switching gears to a age-old topic on tuberculosis. Tuberculosis has been spoken about, I think, since the start of the Pedicon, and we are still talking about it. So, what really has changed in the management? I'm just going to elaborate upon it and the evaluation of tuberculosis, the recent updates actually. Um, a short CV of mine. Now, I'm basically an allergy and asthma person. So, I used to get these cases of an 8-year-old Aisha. I'm very sure all of you will be seeing in your private practice also. 8-year-old Asha who came with complaints of a recurrent cough for 2 weeks. She was actually referred because she had been having several episodes before this and she's been getting a bronchodilator. And since being an asthma person, I was referred this case. And this episode, at this present time, though she was on inhalers, it had lasted for more than 2 weeks. Child on arrival, she is appearing dull. And when inquired, the mother says that she seems to have low grade episodes of fever this time, which was not there last time. And usually she is a very picky eater and she doesn't eat well and eats only junk food. And this week she seems to refuse even that. Her weight and height, when I checked in her older charts, whatever records I had, it has always been on the lower side. So the diagnostic dilemma as a practitioner is one. Is it a cough variant asthma? Should I label her at that? Or should I have to optimize her medication for asthma? Or I'm missing something else? As a practitioner in a private practice, how do we proceed? We have evaluated the family history. We don't usually get a history of contact with tuberculosis, and same in this case. The same condition has been existing before. So, what would be my next option as a practitioner? I asked her when she has taken, should I treat her with antibiotics, just ask her to continue for 2 weeks or come back, or treat her with again a bronchodilator, or shall I take a chest x-ray this time because her symptoms seems to have some low-grade fever, but I don't have the option of admitting her and checking out the fever. And anyway, so I just go ahead and take a chest x-ray this time. And as you can see that there are some highlight notes which I noted here, which is really doubtful for me that this is I'm dealing with something else. But am I correct in doing this? So this is the question I have. So what does the recommendation say? What is the diagnosis confirm that it is something which I'm dealing is not a cough variant asthma? Should I investigate this child further? And if so, how do I proceed? So these are the things that come to me as a practitioner. So yes, there is a need for these topics. There is a change in the recent diagnostic modalities that helps us to find out what we are really dealing with and how to use the tools wisely in our practice. So there is about estimated 3.33 lakh children in the 0 to 14 years age group in tuberculosis in India. And it has significantly risen after the COVID because of the increase in the adult tuberculosis also. And India alone in the pediatric age group contributes to about 13% of the caseload all over the world. But only 20% of the cases we are able to confirm microbiologically. Is it okay? No. And if you look at the characteristics of tuberculosis in children, they are really very unique. Because one thing is the symptoms are overlapping with a prolonged viral cough or a cough variant asthma, and they tend to swallow sputum. There's a paucibacillary type, and very difficult access for us to get the samples, and there is a lower sensitivity for the microbiological test so far. So, has there been a change in the way we are approaching? According to the latest NTEP guidelines, we need to search for symptoms of presumptive TB. And what are they? They are the cough more than 2 weeks, fever more than 2 weeks. There is evidence of definitive weight loss or a failure to thrive. There is a history of contact or an exposure to tuberculosis in the past 2 years. And there is a gradually enlarging painless lymph node, especially in the neck, or they have some other gibbous deformity. Of course, this case, there is a cough for 2 weeks, and mother says there is a documented episode of a low-grade fever for 2 weeks. So, should I suspect in this case of a presumptive TB? And when you are suspecting, the guidelines say, please go ahead and do a chest X-ray. And they have also suggested that nucleic acid amplification test or the TrueNAT is preferred over smear microscopy, and the gastric aspirate or a gastric lavage or an induced sputum has to be obtained for samples in these children. So coming to our case, yes, Aisha is a case of presumptive tuberculosis and she did have cough and fever. So what I did is I have done chest x-ray upfront and chest x-ray is also doubtful and I need to rely on this nucleic acid RCB NAT, our smear microscopy. But as a private practitioner, do I have an access to the same? Yes, the topic is needed for me to understand the same. So the conventional management has been what we have known as only the smear study or the LG culture or the BACTEC method. However, smear had pure sensitivity. The turnaround time for the culture has been really very big for the, and our accessibility to us, that also was very less. And there was no advanced diagnostic tools now. Now that has completely changed and there was also initially no tools to find out the drug resistant. But now that there is a risk of increased risk of drug-resistant tuberculosis. There is a risk of delay in the diagnosis when they rely totally only on smear and culture. But approved molecular tests have come and they have combined with upfront universal drug sensitivity testing. So the new diagnostic tests which are available to us through NTEP platforms as well as in private practice are the real-time PCRs. Less available are the line probe assays, loop-mediated isothermal amplification, and also antigen detection in a lateral flow market. Of course, it may be confusing, but let me put it in a very simple format. One is this molecular assays. This is easily accessible because even when we need to know the smear, we need to take the induced sputum. So once we have this, any of the sputum or the gastric aspirate, we could send it for this test, which is an expert MTB test. This is an automated PCR. One of the biggest advantages, we get the results even in government sector the next day or the same day itself. And it's a gene expert platform. This relies on the PCR amplification and detection symptoms. Initially, we were talking about NAT, but this is a little different from that because this is the changes are integrated into the same cartridge. This is only one single step. And the assays is very sample reagent which is used to liquefy the sputum is also bactericidal, hence no bio threat to anybody of us. Now we are moving on to another latest platform that is going to soon take over this expert also, TB expert also, which is the Ultra. Now the difference between the expert MTB and the Ultra is the amplification probe is more than two is included there. Whereas in expert, we have only one probe that amplifies one particular part of the DNA of the mycobacterial here. So here the amplification targets, they have increased to 2. So it's got a better sensitivity and specificity. And there is a large reaction chamber for the reactions to occur. And it's also using temperature-based analysis for the diagnosis of a rifampicin resistant mutation also in a single step. And there is a 4 probe in the rifampicin resistance, which is the RPOB gene. So this is a very, very easy, in a single step, you are able to find out the presence of the bacteria as well as find out the resistance to the same. But everything is now about made in India, and this expert and expert Ultra has been from US. The main reason is they need a very bigger chamber, very bigger institution or lab for it, and also have to maintain the temperature. But we know we are working at the level of a PHCs or in the clinics where it's not able for us to get to the temperature. We do not have access to such a lab-based facilities. Then what do we do? Now this Malbio Diagnostic in Bangalore has incorporated this technique. But what is different from what has been in the expert is it suits to our climate. It is able to work in the room temperature where in the deepest of the remote centers of India also can have access to that with the same sensitivity and specificity as that of the expert Ultra. So this has really changed the way we are managing tuberculosis in India. And WHO has recently in the latest recommendation recommended this on par with an expert Ultra. So what are these two tests, which is TrueNAT for MTB detection, MTB plus and rifampicin detection assay. The only difference between the expert and the MTB TrueNAT is you need to do it in a 2-step method. Once you give the cartridge, you can see the chip which detects the MTB. Once it does that, the second step is you'll have to go to find out the resistance again in a second step. But that is not a very big major hassle, I would say, because one, the cost of detection is coming down significantly. Second, we are able to do it at a temperature which suits to Indian condition. Third, this instrument can be carried to the deepest of places and to the remote places also. In fact, in Bangalore, there has been a very big study done on the same, and those studies have been extended to 5 multicentric studies, including Africa, and they have actually validated with WHO. So the detection with TrueNAT test, it's developed by the Indian firm, whereas expert, you have a newer generation nested PCR. As I said, in India, there's also a problem of electricity. You need a complete continuous electricity for expert ultra, but that's not required for TrueNAT because it's easily battery operated. The only disadvantage is a two-step process for DNA extraction and for finding the resistance. Otherwise, this is almost equivalent to that of the same. So the advantage is it's a real-time, use automated battery-operated devices with in peripheral labs with minimal settings. Report we get within 1 hour, and if found positive, you get done the assay. So these are the recommendations which I've taken from the WHO that has said that if you have any child with signs of symptoms of pulmonary tuberculosis, expert MTB is you have this with a moderate certainty for sputum specificity. And in children who have pulmonary tuberculosis, expert ultra has got a low certainty of evidence, but it has the test accuracy is low in nasopharyngeal aspirate, whereas in sputum it has got a moderate affinity. What happens to other forms of a cultural, other forms of extrapulmonary tuberculosis like TB meningitis or the lymph node biopsy? Here again, they can be used as an initial diagnostic modality, very easy for us to access. However, they should be used for rifampicin reduction rather than the culture and phenotypic DST in those cases. So we can say into TrueNAT MTB for the extrapulmonary tuberculosis, again there is a conditional recommendations for the same. Now, one more step, this we know, expert ultra and the MTB. One more step is the loop mediated isothermal amplification. This is a manual assay and it is still more easier. The only thing, it's a visual one. You do not find the resistant here, but this is an alternative to smear microscopy as the initial test. It's also a follow-on test to test whether the smear has become negative in cases of the adults. For the recommendation for children, at present has been extrapolated from what has been in the adult studies, but that is because the usage has been very limited and has been limited to a certain centers only, and we have not been able to use it in the periphery. But once it comes, a person in the lab within a matter of 1 hour can tell you, he can assess and tell you whether the smear is going to be positive. But this cannot replace expert MTB or RIF. This can be an initial screening test. Once it's positive, they can refer to a higher center for the same. And what has changed in the diagnosis is the line probe assays again. So this is used in smear positive specimens, and particularly for practitioners who get the expert ultra, we are able to find only the rifampicin resistance. But what happens with the increase in the multi-drug resistance, we do need this LPAs, which will diagnose not only the first line drug resistance, it also detects the second line resistance. So we need to send these cases which are smear positive for the line probe assays. They do not, they have an add-on to what we have as a culture-based DST. So culture will take about, maximum 42 days or even 6 weeks for the liquid culture, whereas a line probe assays will give you the resistance once you have the sensitivity immediately to you, so you can determine what category the child belongs to. This is again a DNA strip based test, and it also looks at isoniazid, rifampicin, pyrazinamide resistance at multiple probes here. But one thing is, it is little more complex than what have been used in the expert ultra. Now, second line LPS have emerged both for fluoroquinolones also, as well as injectables, anti-tuberculous drugs, which we have been using, and has also been able to test for ethambutol resistance. And this is one another point of care testing, which is the urine lipoarabinomannan assay. It is available only in one center in CMC, but this is a potential point of care test. And again, it is a visual strip cut method, just like a pregnancy test. Once you put the sample, if you get the 2-line positivity, you know that this child is going to be positive for tuberculosis. Once it is that, we then extend it. This is much more easier because we do not need to spend our time in sputum induction. And if you do not have the facilities for an induction sputum or for the gastric aspirate, once you find this test to be positive, you need not treat the child. Otherwise, if you do not have the test, our intention will be to start on antibiotics, wait for 1 more week, or start on bronchodilators. If you feel it's going to be more of a cough variant asthma, make the child wait till you see the response. But once you have the lateral flow urine assay, you will be able to do it in your clinic find out if it is going to be positive, you're not going to waste your time on that. You're going to refer to the child immediately to the other centers where the other further tests can be done. So they have improved sensitivity for diagnosis of TB, and especially useful for those children who are co-infected with HIV and also have a low CD4 count. So this could be the rule-in test for TB patients with advanced immunosuppression whom you cannot find out by other technique. For a private practitioner, what it implies is this is a point of care testing, at which point I'll be able to decide whether I need to go ahead with induced sputum and do it with TrueNAT, or I'll have to go ahead and refer the child for further analysis. Cultures, if you look at it, are they still valid? In the past, we were using the solid culture, Lowenstein Jensen medium, but now we have been going more into the BACTEC methods, the liquid culture. The turnaround time has been definitely shortened with this, and one culture is positive. They can be taken for the line probe assays, or they can be used for the traditional drug sensitivity methods. So this is like a very, this distilled there. This is the gold standard. So children who are turning out positive with the expert, you still refer them to this culture, but you do not wait. But once the expert is there, you know that the child is having pulmonary tuberculosis or the extrapulmonary, go ahead and then treat that for the same. So the pyramid of tuberculosis diagnosis has really literally changed by waiting for characteristic symptoms, looking at the tuberculosis skin test, and going ahead with a conventional radiology. Once you are confirming that it is going to be positive, then going ahead with a smear and culture, which has changed on into a pyramid format where you look into everything at the single point of time. You look at the characteristic symptoms, you look at IGRA, you look at the conventional radiology, as well as proceed with your sensitivity testing for both the microbiological confirmation as well as for the drug sensitivity testing. So this has really changed the way even we practitioners are looking at it, and not only restricted to the institute, it has taken to the clinic level too. So coming back to the case, we have a clinical suspicion very strong. The X-ray was suggestive of tuberculosis. We made a diagnosis of a presumptive TB. So this child will have to go for a bacteriological confirmation, and what point of care testing is available is a TrueNAT, and maybe the urine assay is going to come back in the future. So if a clinician is not getting the sample, refer to the nearest TB centers. So in summary, what I would say is definitely pediatric TB is a slowly growing menace, and rapid molecular testing has changed the approach to the management even for the practitioners. A good history taking and a clinical diagnosis is still the backbone of management, because without that, you wouldn't be proceeding with the other things. Chest X-ray is the next step for all cases where you have suspected. And if the chest X-ray is suggestive, think about presumptive TB, and bacteriological confirmation with testing for resistance is definitely the next and the most imperative step, which as a clinician you will be doing. And among the 4 types of tests added, PCRs, LPL, LAMP and urine LPS, definitely PCRs have come to us as a point of care testing, and clinically relevant for us is the same PCR here. So Indian-based diagnostic modalities have actually been on par with the Western cultures, and there are more studies to support the same. So we could use it with a greater certainty in India. Thank you for listening to me for this topic. Thank you.
Thank you, Dr. Narmada. Any questions from the audience? If there are no questions, I'd like to, how relevant it is for using it as a first line. Anyhow, you'll have to go through the skin testing, your chest x-rays.
Only the chest X-ray is the first step, madam. Once you are doubtful in the chest X-ray, go ahead and do it as the first step for expert team.
Okay, how much is the cost for every one of the tests you have been talking?
Now with Nikshay, private-public partnership, you can actually call there is one person assigned to every clinic or the hospital from Nikshay. So if you can call the person, this test is available free of cost to anybody you are suspecting of presumptive TB. So there is no thinking about the cost factor at all. And that person, he is a nodal officer for every hospital and clinic. He maintains communication with you and he gives the results not more than 48 hours. And if it is going to be positive, they inform us also, and they also have the thing that they give the drugs also to us, which we can disperse from our pharmacy. Monthly drugs are provided to the practitioner, so there is no fear that the patient will go into the government sector. Some patients do not want to the government sector. That is also taken negated here, because as a practitioner you can collect the sample and give it to them. As well as drugs, you can give it from your own clinic. One thing is you have to maintain the record. So no problem of cost here.
This is through the government sector?
Government
MEP?
setup, ma'am. Nikshay.
Okay.
There is, you are given, the clinician is given the particular address, your ID, everything is given. So it is very convenient, and every hospital has been appointed a nodal officer for the same.
Okay. Thank you. If you don't have any questions, we'll wind up the session.
Thank you, ma'am. Thank